Good morning, everyone. Good morning and happy Wednesday. Welcome. If you're joining, could you just drop me a 1 in the chat so that I know everything is working, as I continue to admit a few little stragglers who like to keep me on my toes with all these buttons. Oh my goodness. Thank you very much, Patrick. Anyone else? Goodness me, it's all happening. There's so many beeps going off in my head. It's amazing. Right. Gosh, how time flies. Here we are again, once again, doing these webinars. It's like you've got nothing else to do. You just sit there and wait for these webinars to happen, right? Right? Everyone's just twiddling their thumbs, waiting to see us on the screen once again. All right. I'll stop teasing. I know you're extremely busy people. So we've only got you for half an hour, so we'll make the most of it. An icebreaker, if you will, then, to kick things off. One question from me today. What's that one task in your day that you'd really love to not have to do anymore? That one thing that takes far too much time, steals all your time, brings you little to no joy. I've got one, and I'll tell you mine if you tell me yours. Work. I think that's an exceptional answer, Graham. You probably win the prize. But, you know, outside of emails, Sam, do you know, I was hoping somebody would say that, because mine is emails. I would love somebody to sort through my unread emails. I won't tell you how many I've got. It's appalling. I'd just like them to tell me which ones are important, which ones are totally pointless, so I could get to them. Joe, yes. And that one's been uplifted a couple of times. Complaints. I completely concur with that one. Getting out of bed. Terry, well, hopefully we'll make today a little bit bouncier for you, and you can have a good Wednesday on the back of it. All right, awesome. Thank you for responding to that. That was useful. Right. We have got some fantastic content for you today, and an absolute powerhouse of knowledge in the hot seat as well. So a bit of housekeeping before we get started. Firstly, to say that the call is going to be recorded for prosperity and sharing, but you know that. If you need to miss anything, if you need to drop off, you're not going to miss anything. And as I say, we're only going to keep you for about 30 minutes. Second of all, we love the questions, especially Sharon. She really, really enjoys them. So please feel free to drop those into the chat at any point. We'll get to them when we can. As I said, the lady in the hot seat this morning is an absolute knowledge monster. That's what I've dubbed her. So please do make the most of it and keep those questions coming. My name's Lucy Glynn. I'm the community manager here at Exxon Health. And with me today, I think I've built her up enough. It's the absolute wonderful Sharon Hanley for her first time in the hot seat. How you doing, Sharon?
Thank you. I'm doing fine. Thank you very much. I've made my way into London first thing this morning and managed to find myself a cubicle at Tech UK, all set up, loved in a little tiny cubicle. So I made it on time. Proud of myself. A
woman with fingers in many pies. I tell you, juggle it all. I'm assuming that many of our guests today know who you are and a bit about your background. But for those that don't, would you mind introducing yourself?
So, yeah, I am. I tried to make that work. So first fail, didn't have my cursor on the screen. So my name's Sharon Hanley. I'm Managing Director of Hanley Health Limited. Some of you may or may not have heard of us about sort of on LinkedIn as well, working with Max Gatlin as well, who also sort of works in Hanley Health. My journey in general practice started around about 2000, working in general practice. I was an IT manager and also a secretary. And that's where I think my bedrock of actually primary care was born. Obviously, doing all the medical secretary work for 2 days a week with general practice, doing the GP letters, getting to understand the processes, and then actually looking at the IT. We looked at the good old recoding days, the documents, sort of bringing them all in to make sure that we can do all the recall, and basically trying to digitize primary care. So that was my sort of into primary care. Well, forward sort of like 25 years, we've sort of worked in primary care, in community, in the acute sector. I've now went out and did my own business, and just last October, we were nicely sort of brought together with Exxon Health as a sister company to deliver health tech and all the products and services into primary care. So I'm assuming all of you may have Surgery Connect, so the cloud-based telephony service from Exxon Health. You may or may not know about Surgery Assist, the digital assistant. And of course, there's our access dashboard that if you are currently using Surgery Assist, you'll have access to the Surgery Insights dashboard as well. And one of the big things, that we came into this for really, is that we could offer that more consultancy services to support general practice in optimizing some of their services and their systems and their processes. And that's actually where this was sort of born from, because I get lots of conversations with sort of digital transformation leads, ICBs saying, well, we've got a business case to fill and it needs to be in by next Friday. Can you do it on something that you'd like to buy? And of course, we know that doesn't really work well. And I've seen that for years. The end of the year, there's a little bit of money left over. Oh, here's your template, go and fill it. So I'm here today really to just to touch on some really key things that I think will really make a good business case for. And of course, we're going to discuss a digital front door to primary care. And again, of course, you know what products we're doing here at Exxon Health. But of course, a digital front door, there's other things out there. So this is really an opportunity to use the data that we've got, some insights that we've got, and actually a good business case will always have 2 solutions as a minimum. So we're not trying to sell you anything here. This is really about how you can build a story to help you procure something and get a good pass on your business case. Okay, so
Sharon,
we'll move.
Just before you move on, have your lights gone off? You've suddenly disappeared. Not to worry, it doesn't matter. We won't halt proceedings, but just to let everyone know, Sharon is still there, as long as you can see what you're doing.
There we go.
There you are. All right, we can see you again.
Just have to open the door a little bit. Little cubby hole. Right. So yes, what is a business case? And I'm sure I'm not speaking to anybody that doesn't know. But just for basics there, it really is a document that justifies that project or that investment, by outlining, as you can see there, the benefits, the costs, the risks and the expected outcomes. It's very straightforward, but it's got lots of headings most of the time and it really does confuse people. But what we're really trying to do is get to that little button that's sitting behind those decision makers to say, do you know what, this looks like a great initiative, a great project. We want to support it, and they've given us enough detail here to make a decision and just put that business case through. The problem is templates come in all different shapes and sizes, even within the same organisation. They have different headers, they have different requirements. Standardization is also a big key thing that we would like to try and do as part of our consultancy services, just to help people do things like this as well. So we know there's a lot of different sort of templates that you can be asked to complete. It does need to be well structured, and actually a lot of the work is done well before you start completing a business case template. And that's what we're going to look at today. But it is, you do need funding. There is money out there. We can go to anybody. It's not just about going to your ICBs. There are local charities. There's lots of areas and places that we can go to for funding that you may or may not know about. And we've also got information on those funding streams, but that's a different story. We're on business case today. So just to go down to the next one, here you go. I've got a list of typical headings here, and there are a plethora of them. The ones that I'm going to really focus on today are those in orange, to try and really pull out the what and the why, because I think that does get a bit confusing, because sometimes there is so much that you may want to do and what it is that should be done, and then the why can get a little bit blurry as well. And the benefits and the impact analysis, of course, for us, we're always trying to look at improving access, and we're going to focus on that today as well. And the cost analysis, and how much does it actually cost to deliver some of these solutions, and where we can make any savings. And then what do we do with the savings once we've got them? Okay, so we'll go back into that one. Stakeholder analysis should be orange. It should actually be, bellowing yellow, but we'll come back to that one as well. So that's the typical business case headings. And I don't know how many of you have done business cases before. I was going to put in a little Slido in here, but then I realised actually it's only a 30-minute session, and that could have probably got a bit of a mess.
Sharon, we don't need Slido here.
Yeah.
Put a 1 in the chat if you've done a business case before. Give us a 2 if you haven't.
Yeah, just to get a little bit of an idea of what people are doing.
Keyboard.
That's exactly what I'm going to ask you, Lucy. Type it in.
Thanks, Patrick. So we've got a mixed bag, a few 1s, a few 2s.
Okay, that's good. So we're speaking to different people. That's nice. So you'll have some people with some, sort of experience there as well that may obviously want to put some comments in the chat if you do.
Sharing is caring, people.
So one of the the big things, obviously, for those of you that have done business case, is sometimes they get turned down. And there's lots of reasons. And I was also going to ask people sort of, if they've done a business case, what has it failed on? What was it that actually it didn't get through? Why does it fail? And that's a big issue as well. And again, I've put the ones in orange where we find that actually business cases don't come through because actually they haven't quite justified the purpose. They haven't quite aligned to any strategies. And actually the strategies are what really drive us. Those strategies, of course, can be national, and we know that there's sort of like plenty of them around, and they come out every year and they get all confusing. But you've also got your local priorities, which, you know, if they've got the strategy right, that should all align. So we should be able to, you know, really build a big picture, not only sort of resolving some of the national strategies, but really looking after our patients and our registered cohort population. And I think that's the really key thing when you're doing a really local business case, is making sure that you're actually making a difference to those that you're actually looking after, and then just look back at the strategy as well. And it should all match up. And again, the stakeholder engagement. Sometimes a business case can get to, you know, to a board, and it could be 80 pages long, and actually there's been no engagement pre the business case getting to a board. So the idea of this, and what we're going to discuss today, is how you actually bring your stakeholders along with you, and you actually use them as your sounding board for your idea. It's not a case of writing a business case, putting your idea there, your justification, your cost analysis, and sending it in. It just doesn't work. You need your supporters in that room. You need to have got to them at some point in that build up. This is why those last minute business cases are really hard to get through as well, because we haven't really had the conversations with your stakeholders, you know, your clinical directors, etc., to actually get that buy-in, because not everyone knows the issues that are happening with patients, patient complaints and things that are coming through about the practice. You know, some of the staff members may not even have a clue about that, so they don't really know it's an issue. So it's really sort of talking to your reception staff, how they're feeling about it, and doing all your surveys. So there's lots of things we can do to help build that business case up. So again, yeah, just very quickly, sort of what do decision makers look for? And it'd be really good if you guys sort of have any idea of what it is that you feel that your decision makers are looking for. Is it always cost savings? Is it always time efficiency? And what is it that, you know, aligns to that national sort of strategies and how you'd make that work? So I think, you know, what would be good, again, if you could pop it into the chat, what it is that you think is important to your decision makers with regards to the business cases that go forward to them. So
Terry was anticipating the question. She's
who was, sorry?
Value. Terry was value for money is the
and what have we got one from there?
Performance and efficiency, says Michael. Any more for any more. I think the benefits is a really strong one, isn't it? I think that's a really key one, yeah, when putting these things together.
What are the actual benefits of doing it? Yeah, what's the purpose?
Because they kind of, yeah, they underline the value for money, don't they? And they underline the performance and efficiency. If you can really drill down on what the benefits are and how that relates to your stakeholder feedback. Sustainability, that's an interesting one, and one that's becoming more and more relevant and prevalent. I think it's been relevant for a long time, but prevalent is probably the right word. Clarity. Thank you, Kerry. Yeah, absolutely.
Brilliant. And I think it's exactly those that we can sort of have a discussion about, really, is that clear articulation of the problem and then what that solution is. And I think it's having that clarity and, you know, not just sort of bumbling it and trying to put, you know, words on a document and hoping it'll go through. It's really having that thought and thinking about with it along with your stakeholders. So here is all the lovely policies and strategies, the business case, business need, patient need. And I've listed a number on here that are all out there. They've all come out in the new priorities, 25-26. They're in the PCN DESs, they're in the IIFs, they're, you know, all of these things, but they're very much repeated. It says it in every document, but actually, if we look at those, it's what everyone wants to do. The continuity of care has come back out again. There should be ways that we can make that work better. You know, it's always been there, but how do we focus on getting that patient who calls in to see the same GP for the problem they were being seen before? We can get tech to do that, actually. So there's things that we can make happen that you may think is not possible, but actually we can do that continuity of care and help that patient get to that same GP. And I know there's always issues with patients just wanting one GP, but we'd have to look at how we manage that within that tech. We've got lots of things now with developing neighbourhoods. So let's think wider than our general practice. We've got to think outside of our general practice. We've got to look at all those other teams that work across our neighbourhoods. Talk to your ICSs about their plans for the neighbourhood teams and your ICBs, and really get to know, which team should I talk to about this business case? Because actually it will impact them. It actually could impact A&E. It could impact your long-term conditions nurse. So there's quite a lot of things that you could look at, is that who should be my stakeholders. That I'm not saying, you have to have project meetings and you have to align all this, take all this time from people. I'm just saying you just have conversation, have a cup of tea, say, look, I'm looking at putting this business case in. This is my what, this is my why. And I really would, like you have your thoughts on it, and slowly, so then you refine the reasons why. And that business case will definitely sort of get in and get that support from all stakeholders. As I said, the key bit really is having a structured thought process before the business case. Definitely the what and the why. I mean, it's what is it we need to do what? And I kind of think that if you as a practice, as a PCN federation, all of them got together, so what is it we need to do? Well, obviously the policies and all the national guidance tells you the what. We sort of really know the why, but what they're looking for in a business case is that to be really clear, because obviously if you looked at all of those documents that are out there, it can get in a bit of a pickle, most definitely. You're not really sure which one to go for. So it's really the best thing to do is be really clear about what it is you're wanting to try and do with your business case. And to me, the compelling story, that is the piece. If you can do a patient journey of how it would look now if I had whatever was in my business case in place, what would that compelling story be for all of those stakeholders? So to me, telling the story is a really, really key one. Yes, and again, get the stakeholders on board.
Sorry to interrupt, Sharon. I was just sort of trying to develop that thought a little bit. So, in telling the compelling story, is it useful to have evidence? And that might sound like a really obvious thing, but if for example you wanted to tell a compelling story about how you could reduce inbound telephone calls, is it useful to be able to include a case study of a localized practice that's done that and use that as evidence?
Yeah, and that's it. And it's looking at that practice that's very similar to yours, that actually may have the same sort of issues and it's been done before. Absolutely, that does tell a story, especially if we've got some feedback from the stakeholders. And when I talk about stakeholders, that does include your patients. We do go to PPG groups, we have discussions with them, and we talk about what it is that's, what's the problem, what do they want to see resolved. And a lot of it now, through the social media in Facebook, we're actually getting to hear a little bit more. And a lot of practice are getting a lot more support, really, and not so negative, that they're trying to do something, and sharing what you're trying to do actually on your social media is actually a really good way of getting that sort of that patient buy-in as well. We went to a PPG group just recently, and we showed them how, using particular tools is reducing their sort of demand on the telephone, allowing other people to get through. And they love the data. They love the actual sort of looking at that, and they want more of that data. So it's really interesting, and they want a session on the data that's evidencing what the practices are doing to improve access. So that was a key one. Just sorry, got a little bit sidetracked there, but yeah, definitely looking at the compelling stories. So put together. So what is the question? And I mean, there's a lot of questions, isn't there? And as a practice, you might want to pick on one of those. I mean, the top one is like everything all encompassing, if I'm honest. But if you look at all of those sort of going down, what is it that we want to do? SMS costs. So, there's sort of a real overspend in SMS costs. I was looking at some data the other day. We've got a GP practice that sends out the bulk appointment booking invitations over a 12-month period. They've sent 27,000 patients. And actually, Lucy, this can come in the chat. What percentage of those texts that went out, bear in mind that's 2.3 segments each, what percentage of those texts were successful and got a response or a booking?
Oh, so it's a test.
It's a test. If people could pop in.
Big question. Less than 40%, says Graham. Oh, I'm going to go high. I'm going to be optimistic, Graham. I'm going to say 45. Another Graham says 24%. He's feeling a little cynical this morning. Wow, Christopher, not an ounce of optimism there. 10%. Adam, 15. Come on, put us out of our misery, Sharon.
9% of 27,000 text messages sent out in bulk for booking. 9% response rate. So if I was looking at anything in a business case, and I mean, you can look at your data, you can have a look, and it's there, it's in the dashboards if you've got them. Let's focus on that. Let's sort that out. That's not working, and that's just spending a lot of money. Okay, so there's lots of things you could pick from here. What do we want to look at? What is the question for our particular practice? What are the questions across our PCN? Should each practice do something different? Let's, you could decide that at a PCN meeting and really get that engagement of what each practice thinks could be wrong for them. So then that's the what. But then you have to build a hypothesis around that what. So you have to say that to people. So, we've looked at data, we've looked at case studies, and based on all of that, based on our list size, based on our demographic, all of those things that we know we've got data about, if we were to introduce, for example, an AI-enabled digital front door on our telephone call flows, on our websites, we could meet the national and local objectives for improving access, patient experience, and clinical outcomes for patients. That sounds like a pretty cool hypothesis to me. How do we prove it? We've got to prove our hypothesis or disprove it. So you could take each one at a time and you could say, no, that doesn't work. We're not going to put that in our business case because it doesn't work. That's not going to get it. We look at something else where it's worked. We look at some data, we build it up and say, do you know what? I can prove my hypothesis here. That's going in my business case. And that's how we should look at it. And I know this all might take time, but there's lots of, skilled people around that actually work in this area. So we can get that data out. We can support that. The data is there. And I've just heard with that improved patient access and experience down the bottom, the national survey, the health survey is being done via the results being on that survey now, not the GP survey. So I don't know if something's changed there, but that was what was in the priorities documentation. If anyone's got any clue about why that's changed there, but that's where they're going to be measuring that change. And of course, the whole thing about the efficiency savings across a PCN, across an ICB, let's think bigger. What can we actually do if we really worked on those hypotheses first? So that's sort of a bit of work as well, as how do we prove or disprove our hypotheses? But then, of course, once you get your hypotheses and you've sorted it all out, you kind of think, okay, then we've got some data, we've got some measurements, we know what we can reduce it by. Let's get some key metrics against those. Let's put some figures. What can we say we can save, whether it's I might actually be having too many staff. I might have so many receptionists, I can't afford to keep them anymore. Does it mean I can make some efficiencies in actually my workforce? Might have to do that. Hopefully you don't, because there's something else we can do. But it might be a case of actually, I get loads of OC requests and I've got so many that just get sent back out with a link to, another service or a booking link. That's actually work coming into practice that actually is going straight back out to the patient to self-serve. Why don't we let the patient self-serve themselves where we can? So it's having a look at all of these things, getting your figures, getting your key metrics and putting them all down and working out which one for you is going to make that biggest impact. And if it's about cost savings, literally efficiency on cost, that could be down to staff. If it's about making some savings on your SMS to save some money to, procure other products, let's look at your SMS costs. There's, as you see, there's a long list. We can look at lots of things here and we can obviously reduce. By taking people to do things digitally, we can reduce the calls coming in. And that's sort of the big one where we've got lots of data now, because we've got obviously working with Exxon Health as well. We've got all that data coming in. So this is just a very simple sort of example that's basically called like the core idea, example of what we should introduce a digital front door on our telephone call flows and websites, offering patients digital support to self-serve, self-book and self-refer, third sector, hospital follow-ups, the PIFUs come out. So, we can even enable that digitally. We don't have to come into practice and do all that. We can sort that out to support the hospitals as well. All our neighbourhood work, PCNs, GP services, that's our core idea. And why we're going to do that, is that we believe that we can reduce inbound telephones by 30%, reduce inappropriate online consultation requests, reduce our SMS costs. Do you know what I mean? And you can see it all for yourself. This is why we're going to do it. And then you get into the really nitty-gritty stuff, is that how do you actually get your ideas approved using cost-benefit analysis? Now, of course, I've used an example of our Surgery Assist product here on a 10,000 list size. This could be any digital front door. But of course, I can't really put anyone else's up there. So I'm just going to talk about Surgery Assist. So that's it. A 10,000 list size, that's your annual cost. That's my cost. Now, the magic in all of this is actually, what could my savings be? And looking at the data, we've got some receptionist time saving there. This is about 400 calls a day, and we've worked out that about 2 minutes a call. So all the data's in the figuring it out in the background, of course, and I just put the final figures up there. Otherwise, this meeting could be like 2 hours long. So we've got our receptional time saving there, and we could redeploy them, because my business case is actually about improving clinical outcomes for patients, because that's what I want to do. And therefore, I'm actually going to redeploy that time saved with that particular reception staff to do something else. And that to me was my business case. We could, by doing those outbound calls and sort of redeploying those and calling up those patients, actually, we could reduce some A&E visits. Okay, we could reduce hospital admissions using the whole going through the admissions avoidance with our chronic disease patients, monitoring them better by doing outbound calls rather than waiting for them to come to us or 111 or A&E when there's something going on. So we could actually look at those benefits. I know that would depend totally on, you know, the facts and figures around what you've got on your A&E visits, which again, data, it's all it is. And the data is all there. This is all recorded, so we know we can get hold of this data. So there you can see basically from a cost of the digital front door, that is a cost. Everything else is a saving. And there you've got that benefit to cost ratio there. I mean, 1 to 1 is good. But if you were to look at all of those across, you know, your neighborhood, an ICS, and you start looking at this as a bigger sort of bringing into, you know, your trust, your community, your mental health, this could grow, couldn't it? It could be massive if you really looked at it as a whole, as to how we can help patients digitize, self-service for so many things, relieving that time. And you kind of think that's too simple. It can't be that simple. But the data does tell us. So
data don't lie.
That's where data doesn't lie. No. And then, of course, we've got all these lovely additional benefits. Absolutely. Additional benefits. That's all about the engagement, preventative care, reduced appointment demand. There's so many benefits of actually redeploying staff that you just kind of think, this makes so much sense. Why would I not do it? But yeah, that's what your business case is about. So just a quick analysis there, and I realise I'm on 10:28 minutes, so we've only got one more slide after this one. So this here is really sort of giving you some facts and figures around how we got to those that 10,000 savings in A&E visits, the long-term management. So, you know, if you could avoid those admissions with an admission being around £2,000, you know, even just avoiding 10, you know, you can make some real differences here. But it's this that needs to be in your business case. It's that real power of where the benefits are and how we can turn that into cost efficiency, time saving, or all of those sorts of things that we discussed just now. So next steps, I kind of think, yeah, what you should do, get your whats, get your whys, list them all out. And the idea is that you create a very small presentation. It could be an email. It could just be however your stakeholders that you want to talk to respond best. They might not want to all get in a room for half an hour and go through it. They might just want to do it in their own time. So you could just send it out. A couple of slides. This is my what. This is my why. This is what the cost benefit could be. This is how wide it could be. And just filter that out. Start having discussions. I mean, use your PCN meeting, your monthly meetings. Great place to have a big discussion about this. Let's get together. What can we do for our area? And just get together with those stakeholders, and they will put their views in. They will add to your business case. They might take something away that isn't quite right. But actually, the more people you get, you know, in your meeting just to discuss it as an overarching discussion, what should go in our business case. And then slowly but surely you'll get round to refining that business case. Then you can submit that confidently, knowing that you've given those decision makers everything they need to make a decision.
Pavel is coming in hot with a question, Sharon. This is that's been a phenomenal presentation. Oh, he's got to jump to another call, so cliffhanger. We'll get in touch, Pavel, and we'll answer that one. But he was asking about the AI-enabled digital front door and a 12-month free trial. They're cheeky. Anyway, no, it's a valid question. We'll get in touch, Pavel. Sharon, I wasn't lying. You are an absolute powerhouse of knowledge. I think I called you a monster of knowledge actually at the top of the call, which I stand by wholeheartedly. If there are any questions, excuse me, please feel free to just pop them into the chat and we will follow up with the email and answer them where we can. I'm gobsmacked. I think I learned a lot on that and I am very grateful for your time. But that is it from us for today. We hope you've enjoyed it. Thank you all for your participation as always. Our next webinar is planned for the 19th of March, so lock it into your diaries and look out for the link. If you'd like any further information on anything we've spoken about or have any pressing issues that we haven't spoken about, pop your ODS code into the chat and we'll ask your primary point of contact to reach out. We'll make the recording available to all the registered attendees in the next couple of days with all the relevant links. We hope to see you all back again next month for more interaction. But in the meantime, on behalf of all of us here at Exxon Health, we hope you have a very happy February, a very romantic Friday, and we'll see you in March for more. Take care. Thank you.
Bye.
Bye.